Sure. This is Laura Rowley. She's a patient who's now using the Optune device, and this is Dr. Michael Prados, who was my mentor at UCSF in the early 90s. He's a neuro-oncologist at UCSF and a very knowledgeable neuro-oncologist involved in science and clinical trials. I'm the director of the Ben and Catherine Ivey Center for Advanced Brain Tumor Treatment here at Swedish Medical Center. I'm a neurosurgeon and do brain cancer research. This is Mary Lovely, who I also knew back in the 90s at UCSF, and she's been helping brain cancer patients as a patient advocate and works alongside the American Brain Tumor Association and many other organizations. This is Dr. Jerome Graber, who is a neuro-oncologist here at Swedish, who trained at Sloan Kettering in New York and joined us about a year ago or so, and does a lot of good work in clinical trials with our patients. And Ralph Puchalski at the end is a researcher who is a PhD and had worked at the Allen Brain Institute. I think we're being live streamed on Facebook, is that right? So hello to everyone.
Specifically for brain tumors, and we're seeing more attention to research into how do we improve memory outcomes, how do we address chronic after effects of radiation therapy that remains the cornerstone of treatment for most of these diseases. So I think we're also getting more interest, more research, and hopefully improving outcomes, not just in terms of tumor control and eradication, but helping improve people's quality of life and function in addition to that.
Another example is, I've heard that cannabinoids are beneficial. And then, as you know, Maria, I looked into this, and I do have colleagues that are researching specific cannabinoid medications, and there was just a publication showing that maybe cannabinoids can help patients with glioblastoma. But then patients may not have a grasp of the science, and when you get into the details, there are about 15 different cannabinoids, and they each have specific molecular pathways. And so if you just go out into your local store here in Seattle, you may have no idea what you're getting your hands on, and it may be toxic for the patient. So it's a difficult thing to wrap your head around as a care provider, because it's kind of a loose moving target without clear guidelines, as far as I know. What are your thoughts, Mike?
About cannabinoids? I think it would be great if we could have access to cannabinoids to do research. That's a big problem for us, because I think there may be a story there, but we can't get access to do these things on a clinical, except very rarely now. So even to investigate or interrogate the question, we have to do clinical trials. I mean, that's sort of our guidepost to say it's reasonable. There's a risk-benefit ratio that favors a benefit versus a risk. Drug-drug interactions are very important for alternative and complementary medicines that can actually impact the benefit of another therapy So I think there are a lot of issues that have to be addressed. There's not a lot of funding for those kinds of things, and it's sometimes even hard for getting cannabinoids to do the kinds of studies that we need to do. But we are interested in that. We're interested in a lot of alternative medicines, but there's just a layer. There's like how many things can you do with the resources that you have that gives you good quality research that actually definitively asks and answers a question? And sometimes these are fairly low on the totem pole of research. That's not that they're not important to do, it's just there's only a certain bucket of money to do these kinds of things. And that's a shame. I personally think that's a shame.
Question from online, wanting to know about complementary therapies, and Mary and Joe, maybe you can attack that question. Food, diet, drinks, herbs, what other things can I do, was a question from online for her husband to help him with his treatment and all the effects of his treatment that he's been going through.
Yeah, so this is a very common question. And it's kind of another level of research that can be beneficial, but is also a problem, because often we're not getting high quality research that we can give advice based on at the same as when, as a physician, we're recommending from a randomized placebo-controlled trial that was funded for X and Y reasons, we know definitively this or that. Often the quality of research we get for kind of some of the naturopathic and complementary approaches is not as good, but a lot more of them often are addressing exactly what we were just talking about. So effects on kind of symptom management, energy levels, dealing with side effects of treatment and things like nausea, GI side effects. So there is abundant research, but there is really not much education available to a lot of providers about that research. Here, we're very lucky that we have naturopathic colleagues and nutritionists available to us, but not everyone has that, and not in all areas are those people as familiar with kind of the specific and sometimes special problems that our patients deal with. So there is some information out there, but often it's not at the same quality as we get when we talk about specific medications. And again, especially when you're talking about symptom management, I would never really make any blanket statements because I don't think there's anything I've seen that convinces me that there's something that everyone should be doing. But I think it depends on the specific symptoms that a particular patient's dealing with, and you need to get a lot more kind of personalized and tailored. But it's definitely an area where we could use more quality information and research.
I think something that's frequently seen by neuro-oncologists and people like me is, a patient will say, I'm on a ketogenic diet. There's data, I heard this is great or something like that, and there's a person that did great on this diet. And there are sporadic papers and reports, but like Dr. Graber said, it's nothing that I'm aware of that's been a definitive prospective randomized, but maybe I'm missing something. But
I just wanted to also add, I think the question included nutrition as well. Yes. And do you know, in my support group, one of the first things that is brought up is nutrition, because what can I do for myself? How can I control this? And so I often listen to what people tell me. I don't start telling them exactly what. And they're going for supplements and this and that. But after a while, people realize that the important thing is to have a good, strong diet, because you just feel better. You have a balanced diet. And at UCSF and at the hospitals, I really strongly suggest people see their nutritionist, because they sit down and talk to you about diet, and especially the oncology nutritionists know when people are taking Temodar, sometimes you don't feel good. And what are the foods that will make you get past those GI problems? It comes down to feeling good. What makes you feel good when you eat? And it's usually a pretty solid diet.
So hopefully I'm sharing honest information with people, and also what we don't know, which doctors are often not that great at saying, but sharing things that we don't know about some of these other things like nutritional things, using complementary medicine. And any good teacher will tell you that they learn far more from their students than they ever teach. So hopefully I'm listening, and I really do feel that I learn from my patients, and then I can share that with the next patient I have, and hopefully it helps me be a better healthcare provider and advocate for my patients too, by listening to them and learning from them how they feel and what their experiences are.
And one of the more difficult problems is to try and weed through that and understand how to triage. Should I go this way? Should I do that? Should I go out of the state? And that's where the value of a neuro-oncologist who's been academically trained and deals with clinical trials. There's such a great resource to help filter through what this means. Eligibility, phase 1, phase 2, phase 3, this drug with this side effect, this potential risk. And I think that's the important thing. I think and it's unfortunate that patients in this country with glioblastoma, only a small percentage go on clinical trials. In children, like 80% of kids with cancer go on clinical trials. Go see an academic neuro-oncologist who can understand and help basically interpret what these things mean and where it fits in the treatment regimen.
So it changes all the time, literally from day to day, what's available. But we have a number of immunotherapy trials going on now. We will be opening more, and hopefully we'll have more to offer, and ones that more people can get into.
There are lots and lots and lots of novel therapies big studies, little studies, early phase studies, immunotherapy studies, vaccine studies, oncolytic viruses. There are so many things ongoing right now. It's a really exciting time, and it would be so much better if patients are at least potentially willing to think about enrolling in those trials, because then we could get answers a lot faster.
Because cancer adapts and evolves and uses multiple pathways to grow and move through the body, we clearly need things that work with multiple mechanisms of action to kind of block off the ways that cancer escapes from our different treatments. So hopefully combining different methods of treatment, molecular, radiation, surgical, tumor treating fields, things that work in different ways will kind of lead to cumulative and greater long-term successes.
As I mentioned in my talk earlier today, looking at biomarkers, we have some genetic and non-genetic. I guess methylation MGMT is not really genetic. It's a modification of the DNA. It's not a mutation. But in any event, we can look at a glioblastoma and look at the genetics of it and see if it's IDH1 mutated. And that basically, in my mind, means it's not a real glioblastoma. It's one that is in a totally different can of worms. Of the generic glioblastomas or the primary glioblastomas, they're often called, about a third of those will have MGMT promoter methylation, and that is a good thing, because that means if you take Timidar, your body can't get rid of the effect of the chemo drug, so you'll have a better response. But unfortunately, about 2/3 of people with glioblastoma are unmethylated for the promoter, so their body gets rid of the effects of the chemotherapy, and it doesn't have much of an effect. They just kind of predict where you're going to be in terms of your response. Why don't I let the two neuro-oncologists discuss our clinical trials for recurrent glioblastoma? There's a number of studies going on. We have several now about vaccine therapies and immunotherapies. We're starting to see trials now about combining different agents, so combining antiagenic agents that combat tumor blood vessels together with immunotherapies to hopefully have a synergistic effect and work better, and maybe also minimize some of the side effects of the immunotherapies and control swelling.
Decadron seems to be the universal drug to combat the swelling, the edema. And a lot of the times it seems like that's almost worse than the tumor symptoms. Is there something else that doesn't cause or doesn't have all the secondary symptoms?
Your other question about edema, this is a struggle. I mean, steroids, Decadron, is a brutal drug, but it's pretty effective. The only other alternative right now is bevacizumab, Avastin, which we do use for acute swelling or radiation-associated edema. But it's a dilemma, because you're using a drug that is harmful for the rest of the body, right? And maybe even for the tumor, but it does reduce swelling, at least. And it should be used very judiciously, and that's why, again, you have to have a really good oncologist, neuro-oncologist who is comfortable with the drug, knows when to get it down as quickly as possible, and if it's on for a long time, you got to be careful about, getting off of it. I mean, there's a lot of issues related to it, but I wish we had a better drug, but we don't.
I know family members just have to keep on top of those symptoms of Decadron and know that, it can also cause problems with your bones. It can cause your skin to thin. It's not just the horrible feeling that you can't sleep at night. So I found that if they have they do need to know about Decadron and to look it up and to be on top of the symptoms, because sometimes people have to be on it. You can't get off that 2 milligrams or 1 milligram. So as hard as it is, just kind of hang with those symptoms and try to work with each one of them, and that at least helps.
Personalizing the dose of dexamethasone. There are patients who need none and should be on none, but there are other people who need it despite the side effects, and then that leads to more medications to manage the side effects of that medication. But I think it's actually a huge part of symptom management and control, and balancing things and really personalizing patient care. But part of that is also, I think, educating family members. This is why, or if the patient themselves, this is why you're feeling not like your usual self. This is why somebody's maybe behaving a little different than usual. It adds to the chronic stress. If you cannot sleep at night, everyone feels miserable. So there's often this temptation to blame the tumor or to blame the radiation and chemotherapy for some things that might actually be fixable.
I think that the things right now that I'm more optimistic about, and if I was a patient, I don't know if I would make the same choice, but I'm more optimistic about are genomically based approaches, very similar to what you're talking about, as well as immunotherapy-based approaches in a cocktail that would be, and of course I'm biased because I would say I'd want to do it in a clinical trial. But, you know, if my disease was diagnosed when I'm 82 and I was paralyzed and can't walk and can't communicate, I don't know if I'd want treatment. But there are a lot of choices. So I've got to make a choice based on what I want.
Maria, I think you have some questions from around the world.
Online. Yes, we have people listening in from Oklahoma City, Reno, Nevada, West Virginia, New York, Atlanta, Australia, and England, as well as other places. I have a question from online. Any experience with epithelial glioblastoma? That was a mouthful.
No, you're much younger and wiser than I am.
So, you know, I think, again, we talked a lot today about different molecular subtypes, some of which our pathologists now are really good about maybe then pairing some of these unusual subtypes. People talked about gliosarcoma, there's epithelial glioblastoma, there's these large cell variants, there's these, you know, immune cell rich subtypes. So pairing these molecular subtypes, some of which end up on a path report, and some of which we're starting to learn match up with different molecular signatures too. So I think we're kind of just getting to that point where we know that there are different subtypes, and not quite to a point where we definitely know whether to treat them differently or not.
For glioblastoma, if we're talking about that, if you just do a biopsy, that the prognosis is much worse in general than if you do a complete resection. So despite the fact that you know it's an invasive procedure and all these things, I think that the short answer is that if possible, if safe, it's best to get as much out as possible.
We are actually out of time here tonight, but I want to encourage everyone that's listening or anybody that's here to visit Seattle Science Foundation's YouTube channel, their Facebook page, their website. All the videos from all of the educational portion from today, as well as tonight's panel, will all be posted on there, as well as our braincancer.org website and Facebook page, so you can link in and watch all of the videos, including this portion tonight.